Should we start?
Yeah.
Well, good morning. This is Dr. Kawaja, and I'll be introducing Dr. Megri today. Although he's new to our section, but he's no stranger. Most of you already know Dr. Megri. He did his residency training here in internal medicine. One of our best residents. He was awarded as the resident of the year, as well as he was the chief resident here. He then moved on to do his pulmonary critical care fellowship at University of Kentucky, and he's back with us, and we are very proud to have him. He has been an excellent addition to our section. During his fellowship, he was also the chief fellow there, as well as also awarded the chief teacher of the year during his fellowship. He's board certified in pulmonary critical care, as well as advanced critical care echocardiography, which is one of the new fields that's rising up in the ICUs. His main interests are in mechanical ventilation, point of care ultrasounds, shock, pulmonary hypertension, as well as pulmonary embolism. And he will enlighten us today regarding the pulmonary embolism, what are the various challenges and controversies. With the advent of some of these new CT scanners, we are finding smaller and smaller pulmonary embolism. So it is not a very uncommon diagnosis these days when patients are presenting to the hospital. And sometimes we do see incidental pulmonary embolism also. So it will be nice to hear what Dr. Megri has to say about all these controversies and how to manage them properly. So I will forward it to Dr. Megri and would love to hear his talk today. Thank you, Dr. Megri.
Good morning, everyone. Thank you, Dr. Kawaja, for this nice presentation, and thank you all for being here. I hope that you can hear me very well. First of all, I'm happy that I'm back here in Marshall with Marshall family. I'm happy that I'm surrounded by a lot of smart people that I used to learn from them before, and I'm still learning from them today and in the future. So today, what I'm trying to do is I will talk about pulmonary embolism, but pulmonary embolism is a very large field. If you go deep in pulmonary embolism, like you cannot finish talking about pulmonary embolism in like 4 or 5 hours. So that's why today I tried to take some challenging situation and things that we will deal with during our daily basis in the ER or in the internal medicine floor or in the ICU. So the first few slides will be just a review for most of us and maybe a little bit of teaching point to the students and internal medicine residents. But then after that, we'll go deep and dive deep into treatments and how can we treat pulmonary embolism and the mortality of pulmonary embolism. And we'll talk about the PERT team, which is the pulmonary embolism response team. So I will start my presentation with a case presentation. So when I was a pulmonary fellow, I had a 73-year-old patient with a past medical history significant for hypertension, diabetes, and non-obstructive coronary artery disease. He came to the emergency department. He was complaining of shortness of breath and feeling fatigued and tired for 2 days. So the ER physician got his vital signs. Vital signs were normal except for mild tachycardia and hypoxia with oxygen saturation 92% in room air. And otherwise, his cardiopulmonary exam was completely unremarkable. Then they did a blood workup, and before the blood workup, they did an EKG. EKG showed sinus tachycardia, chest X-ray, no significant abnormalities. All of his blood workup were normal, except for the patient had high ProBNP, and he had a little bit mildly elevated troponin, and he was COVID test positive. So COVID test positive in that time when the patient was COVID test positive, that explained everything. Done. This patient has COVID pneumonia and he has shortness of breath and he's feeling tired and he has a little bit of tachycardia. That's it. So they called me, hey, can you please admit this patient to the pulmonary floor? So, and while the physician in the ER talking to me and the patient coded. So they went and run to code the patient. He had one cycle and then I went down and they did not leave the room yet and the patient coded again. So after 4 cycles, they got the patient back and the patient was requiring to be on pressors. So I intubated the patient And then I started to do the patient like a point of care ultrasound. So when I did point of care ultrasound for the patient, so like all of his organs was completely normal except for the cardiac focus. When I did the cardiac ultrasound, I found out that his right ventricle was dilated, and he has McConnell sign positive, and we'll talk about that in the future slides. And he has a positive 60/60 sign. And all of these features, when I saw all of these features, and the patient, he's almost gonna code again. So I said, okay, this patient has a pulmonary embolism. I need to take an action, and I decided to give the patient thrombolytics. So that's his ultrasound. If you look at the long axis view in here, and you see like the left ventricular function is normal, but you see that there's a dilatation of the right ventricle. In the short axis view, you can see that the left ventricle is pushed by the right ventricle, which we call the D sign. And in here, the apical four-chamber view, that the patient has the McConnell sign, which is the movement of the apex with akinesia of the wall of the right ventricle. So when I saw all of these things, I decided I cannot take the patient to the CT scan right now. Patient pressure requirement is going higher and higher, and patient he gonna code again. So I decided to give the patient TBA. I gave the patient 20 milligram of TBA bolus and followed by 80 milligram. And it was like magic. And whenever I gave the 20 milligram, 2-3 minutes after, pressure start going down, patients start improving. So I felt like a little bit of relief. So I said, this patient is stable right now. Before you take him up to the floor, let's do a CT scan. So when he did a CT scan in the patient, we found that in his CT scan, he still have pulmonary embolism. And it's a very high burden pulmonary embolism in the central pulmonary artery. So I said, is this failure of the TBA, or does it take longer time? And what should I do next? So patient is stabilized. So I said, okay, patient is improving. He's still requiring pressors, but patient is improving. So after CT scan, they take him up to the floor, and unfortunately, to the ICU, and unfortunately, his pressure requirement kept increasing and increasing again. So in that time, as a pulmonary fellow, I start asking myself, like, what should I do next? Should I just continue the heparin drip? Should I give him another thrombolytics? Should I like transfer the patient? In that time I was in the VA hospital, they don't have like a catheter-directed thrombolysis. Should I transfer him? Should I cannulate him for ECMO? What should I do? What's the next step from here? And we'll answer this through the our presentation. The next case, which is like just a few months ago, he's a 36-year-old male with past medical history significant for non-Hodgkin lymphoma, who was presented to the emergency department with shortness of breath and cough and mild chest pain. After evaluation, they found that he has a high D dimer, high troponin, and high proBNP. But the patient was hemodynamically stable. He was not hypotensive. He was just short of breath and mild chest pain. So they decided to do a CTBE protocol, and the CT scan showed bilateral central pulmonary embolism with signs of right ventricular strain on the CT scan. Then the question is, what's the next step in here? He's hemodynamically stable. Should I give him TBA? Should I just give him heparin? How can I risk stratify this patient? Where should he go, to the ICU or to the floor? And those are the questions that we will answer in this presentation. All right, so as I said, the first few slides will be just a quick revision. So epidemiology of PE, we know PE like around 1 in 1,000, and the higher the age, the higher the incidence of PE, and it jumps from 1.4 per 1,000 when you are around less than 50-year-old to 11.3 per 1,000 when you are more than 80 years. And overall, the incidence is slightly higher in males comparing to female, but the mortality in females in age 15 to 55 or more than 80 is higher than male. And around 50% or more of the patient who has PE, they have transient risk factor. And 20% are associated with cancers, and the remainder of them, they have like idiopathic or it's a mixed picture. So when we look at the incidence of pulmonary embolism, when we look at the United States and other countries, you see how high it goes, like the incidence per year. We found a lot of PE in our patients. So we don't know if this is like because of the PE became more common in patient, or because we are using the CT scan more comparing to before, and we don't follow the specific criteria to order the CT scan. But what made me happy is like the fatality rate, the case fatality rate, it goes down. If you look at the United States, I think China, they're like, that's a dramatic improvement. But for us in here in the United States, there is a significant improvement in case fatality rate. And so when we think about PE, so we should think about the risk factor. Like we should not just go to the ER, and if this patient is short of breath, let's do a CT scan. If this patient has chest pain, let's do a CT scan. If this patient has this, let's do a CT scan. Yeah, because as Dr. Kawaja said, if you do this, you will find a lot of like subsegmental or incidental PE that we will stuck with it, and we don't know exactly what we should do. We have some guidelines, but unfortunately, it's not a very good evidence behind these guidelines. So that's why try to take it step by step. The first step is thinking about the risk factor. What are the risk factor of pulmonary embolism? We all know the Virchow triad, which the venous stasis and endothelial injury and the hypercoagulability. If you have only one, your chance is less than if you have all of them. So that's like in the second patient, he has non-Hodgkin lymphoma and he has a high risk of forming pulmonary embolism. This is a list of multiple risk factor, and as a resident or any physician, you need to put it in. Give me just a second. Can you hear me now?
Yes, we do.
Yes.
Sorry, the charger. So when you think, like when you look at the risk factor for venous thromboembolism, so there is a strong risk factor, there is moderate risk factor, and weak risk factor. So when you think about risk factor, I will not go over it like over each point, but as a resident or physician, you need to put it in your mind that there's different risk factors, and you need to think about them, and like not all the risk factor are high risk factor for pulmonary embolism. So how does the PE present? So unfortunately, we don't have a specific symptoms or signs that tell us that this is for sure PE. We don't have that, because PE could be completely asymptomatic, or they can come with a sudden death. And fortunately, that this number of sudden death is like less than 5%. So PE could be like completely asymptomatic, could be like shortness of breath, could be hemoptysis, wheezing. They might have tachycardia. They might have hypoxia, and if we are lucky, we'll find signs suggestive of deep venous thrombosis. So that's why I cannot just go down to the ER and say, "Hey, this patient has PE because he has this symptom." So that's why from there we have the clinical probability score. So, and we all know and familiar with Wills score. We can use Wills score, and it has a very high sensitivity and specificity and reach like 89%. And we have the other score, which is the revised Geneva score, and the revised Geneva score, which is more sensitive than Wills score, but less specific. So when you use this score and use your training and your like clinical thinking, so you can know if this patient has a high risk or moderate risk or low risk for having PE, and you can have these scores in your phone in mid-calc, and you can give you the numbers and the risk of the PE. But you will not use these scores in a patient who has like hypoxia because of pneumonia. Or like nowadays we have the COVID-19 patient, they have like severe bilateral infiltrate and they are hypoxic, and then like you shouldn't think about it in a patient who has a straightforward reason for his symptoms. And as we said, the Wills score is slightly lower sensitivity comparing to Geneva score, but it's more specific. So usually like you can use one of those, or you can use both together to increase your sensitivity and specificity. The other score that I found out when I was preparing for this presentation, I didn't know about it before, it's the year score, which is easier, and it has a good sensitivity and specificity as well. It has like reached 78 to 80%. So it has, which is contain like 3 symptoms and 1 lab work. Clinical signs of deep venous thrombosis, hemoptysis, and pulmonary embolism is the most likely diagnosis. So if you have 0 points from those and the D dimer is less than 1,000, not 500, then you can exclude PE. And that was like 78 to 85% sensitivity and specificity. And this is like you can go look at it and see how to follow this score. But these scores has to be used in the proper way and in the proper patient, not on every patient, as we mentioned. So unfortunately, with all of these scores that we have, we still have, like, we do CT scans to people that they don't meet the criteria for CT scan. Only 8% of patients in the United States and 27% in patients in Europe, they have pulmonary embolism after they scanned. So look, like it's there's a problem in here, I think, and I think we need to be more, maybe it's busy service, or we need to be more specific on who should go to scan and who should not, and we'll go over it in the few next slides. So in 2008, they came with a new rule, which is the Pulmonary Embolism Rule Out Criteria, PERC. So they said, okay, if you have a patient who you suspect that he has a PE, and then you did the Geneva score or the Wills criteria or whichever criteria you did, if it was low risk, do not order D dimer if your PERC rule was 0. So what's PERC rule? PERC rule like hypoxia, unilateral leg swelling, hemoptysis, previous venous thromboembolism, recent surgery or trauma, age more than 50. And I will go over it in step by step. But they said you should use PERC if your symptoms, like your symptom and signs was suggestive of something else, and the probability score was very low, and you did PERC and PERC was low, then that's it. You should not do any D dimer, because if you do D dimer at that time, it will give you false positive results sometimes, and you will end up with CT scan. Talking about D dimer, as we know nowadays, everyone will get D dimer who comes to the hospital because of COVID-19 pneumonia, and if the D dimer is high, we'll like consult everyone. So nowadays it's better comparing to the beginning of the COVID era. But D dimer is not a specific test. D dimer is sensitive for PE, but it's not specific test. And D dimer can be high due to multiple other reasons. That's why you should use D dimer with the other features and the probability criteria. Don't use D dimer by itself. If you order D dimer just for D dimer and it came back high, and you don't have symptom and signs suggestive of PE, you should not act to D dimer. So you have to go with like your symptoms and signs and the probability criteria before you use D dimer. And the other thing about D dimer, which I found that many of us we don't use, but it's very specific and sensitive, and actually they recommended to use it in the guidelines, and these which is adjusting the D dimer according to age. If you are less than 50-year-old, then yes, you can go with the D dimer more than 50, more than 500, it's high, less than 500 is low. But if you are more than 50-year-old, you should adjust your D dimer. Don't go with the level that they give you in the lab. So there is a trial called the Adjust PE, and they found that increased the sensitivity and specificity of using the D dimer when you adjust it to age. Like, let's say that if I'm 70-year-old, my normal D dimer, upper limit of D dimer, should be like 700. So if I did the test and the D dimer was 600, that's not high for me. That's normal for me. So more than 700, it's the upper limit that I should think of PE. That's in top of the criteria that you did before you even ordered the D dimer. All right, the last slide in reviewing in PE, imaging. Imaging, and we know the gold standard is pulmonary angiograph, but nowadays we do the CT-PE protocol, and it has very high sensitivity and specificity. The negative predictive value of that is 98.8%, so it's close to 100. So that's why we all now do the CT-PA. But unfortunately, sometimes we cannot do the CT-PE protocol because of any reason, because of contrast or allergy or anything like that. We still have other things that we can do, which is the VQ scan. So we can do a VQ scan, and the VQ scan will give you if this patient has a low probability, intermediate probability, or high probability for having PE. If I cannot do the CT scan, I cannot do the VQ scan, I still can do an ultrasound, at least give me like ultrasound in the legs. And because more than 50% of patients who has deep venous thrombosis, they will have concurrent PE at presentation. So that's why it's not the end of the world if you cannot do a CT scan or VQ scan, you still do ultrasound. And this is very easy to learn, and you can do it by yourself, and then you can confirm it by asking the tech to do a professional ultrasound. All right, so a quick review, how can you work up the PE? If the PE criteria from the beginning was low, the next step will be a PERC rule. If the PERC rule was 0, there is no points at all, then you don't do anything. No D-dimer, nothing. Stop in here, it's not PE. And if the PERC score was 1 point or more, that's when you do the D-dimer. And the D-dimer, if it's less than the adjusted age, then you stop in here. You don't do anything. And you have to think of, is there any explanation that the D-dimer was high or not? If the D-dimer was high, and then that's when you think about option A and option B, and we'll talk about it. But let's say from the beginning, when you did the Geneva score or the Wills criteria and the pretest probability came back intermediate, that's when you straight order the D-dimer. If the D-dimer was negative, you stop. If the D-dimer was positive, more than the upper limit of normal, then that's when you do option A and B. What's option A and B? Which is when you have a high probability test, when you have if I have a patient has a shortness of breath and he had the hip fracture recently, he was in the hospital and he has chest pain, I don't need a D-dimer for this one. That's straight for a CT-PE protocol to know if this patient has a PE or not. So option A, which is CT-PE protocol, and if I don't have the facility to do a CT-PE protocol, or the patient cannot move, or he has an allergy from the contrast, or his weight, or anything like that, we can do VQ scan. VQ scan sometimes is a little bit difficult in the interpretation, because the result of the VQ scan will say low probability for PE. What does that mean? Then it's done. It's not PE. Rule out PE. If they say high probability for PE, this patient, yes, he has a PE, and treat him as a PE until you have the time to do a CT-PE protocol if you want. If it's intermediate or non-diagnostic, in that time, you need to do an ultrasound to see if your patient, he's one of the 50% that he will have DVT concurrent with the PE. So that's how you work up a PE and how to reach the PE diagnosis. So what's the rule of echocardiogram in pulmonary embolism? So the rule of echocardiogram or point of care ultrasound in pulmonary embolism, it's mainly for acute PE or patient with submassive PE. So when we talk about acute PE, acute PE means that I have a clot in the pulmonary artery. It developed all of a sudden, and as we know, the right ventricle, it's not a high pressure ventricle and has a high compliance. So the first thing that it will happen to compensate, it will dilate. So we'll see dilatation of the right ventricle. And because in increasing the pressure against the right ventricle, it will start pushing the left ventricle. And we all heard about McConnell sign, which is the movement of the apex with the akinesia of the free wall of the right ventricle. And because of the high pressure, the pressure will go back to the tricuspid valve and will give us tricuspid regurgitation. So I will jump in this sign, which is 60-60 sign. This is very highly sensitive and specific sign. And it's reach 98% sensitivity and specificity for acute obstruction in pulmonary artery, and which is the most common cause is pulmonary embolism, which is we measure the right ventricular systolic pressure. And we don't have to go over how to measure it today, but you measure, and for sure there's a lot of cardiologists listening right now, they can do it better than me. And the thing is, but it's easy to learn. So you do what we call the RVSP, the right ventricular systolic pressure, and if the RVSP less than 60, that's the first 60, and then you put your pulse wave Doppler in the pulmonary valve, and you measure the deceleration time of the pulmonary flow, and if it's less than 60, that's more than 98% sensitive and specific for pulmonary embolism. And that was positive in our first case presentation that I presented in this presentation. So that's the use of echocardiogram and pulmonary embolism. So now, why we are afraid of PE? What's the point of like having this presentation and talking about PE, and we are afraid of PE, and what's the next step? Because we don't want our patient to go inside this vicious cycle. Because as we said, the right ventricle will get dilated, and then we'll have a little bit tricuspid valve insufficiency and increase the tension of the right ventricular wall, and that will lead to inflammation, increase the oxygen demand, decrease the RV contractility, decrease the RV output. So then the next cycle, we have low LV preload, and that will lead to decrease in LV function and hypotension, and it goes on and on and on until we have obstructive shock and we have death. So we will be happy if we stop this from the beginning in here, instead of like waiting till it reached the death. We need to like try our best to stop this circle or cycle in here. All right. So how can we assess, that's one of the most important slide, how to assess the risk for this patient. We all know in here in this room, we know that, and nowadays it's not this room, we all know here in front of our screens that having a PE with hypotension, that's what we call massive PE. So massive PE, it's not where is the PE, it's not anatomical position, it's not how the patient look like, it is if the patient has a pulmonary embolism and he's hypotensive, his systolic blood pressure less than 90 or less than 40 from the baseline, or the patient on vasopressors, or the patient has a sudden death or cardiac arrest. That's massive PE. We all know massive PE, and thank God that this is like only 5 to 10% of patients will present of massive PE. But our main topic is about how can I risk stratify patients with intermediate risk PE, which we call submassive PE. We have an easy score that you can have in your phone and called the Pulmonary Embolism Severity Index. And there's the revised or simplified Pulmonary Embolism Severity Index. And that's very helpful, and it's very sensitive and specific, and it shows that if your risk in that score was low, so that's the 30 days mortality rate was around 2.3%. If your risk was high, it reached like to 10.4 or 11.4%. So any patient who has PE, you should run this score on him to know where is your patient at. Is he low risk, is he intermediate risk, or is he high risk? So the other feature that we can use to, that's the PISI score, by the way, and the other feature that we can use to risk stratify our patient, we said in that circle, we said that if the patient get inside that circle and get like the right ventricle get weaker and dilated, so what will happen is the heart will start releasing the cardiac enzymes and cardiac inflammatory markers. So the cardiac enzyme that we talk about, like troponin, in 30 to 60% of patients with PE has elevated troponin. And when you have elevated troponin, that's increased the mortality 5-fold in the 30 days mortality. So that's why any patient with pulmonary embolism, we should check troponin if the patient has a diagnosis of pulmonary embolism. And the other one that we don't have in here, the heart type fatty acid. And the other one that's very common, and we have it everywhere, is the ProBNP. The ProBNP is exactly like the troponin. It's 30 to 60 or 50% of PE patient has positive ProBNP. And that increases the mortality if it's high, and which tell us that the heart is struggling to push the flow against this obstruction. So we need to combine all of these risk factors, the PE severity index and the troponin and the echocardiogram and the CT scan to put our patient in this table, which is very important. That's the European guideline. They follow this table. We follow massive, submassive, and non-massive. But I like this, and most of the PE and the PER team, they follow this protocol or this table. And because you can stratify your patient if he's gonna decompensate and he will get bad, or where he should go to the ICU or to the floor. So as we mentioned, we know what's high risk. High risk means that high mortality risk means that massive PE. The patient is in shock or hypotension. That will not spend time on this. But what we care about, intermediate risk. Those patients who they might compensate in the next 24, 48, or 72 hours, and they will need like aggressive measurement. We need to pick in those patients and make more workup and more evaluation, and that's where the PER team has the main effect on these type of patient to know exactly where should I send my patient and what's the next step. So how can I risk stratify them? So all of them, they have no hypotension, because if you have hypotension, done. It's PE, massive PE. And just make sure that you are hypotensive from the PE. There is nothing else going on. But if you have hypotension from the PE, it's done. It is massive PE, and we don't think about what's the next step. We'll talk about it later. But if you don't have hypotension, you look at the pulmonary embolism severity index. Pulmonary embolism severity index, if it's high, which is around 3 to 5, that's you have positive points. So this patient has to be in the intermediate risk. And then you look at the troponin and the ProBNP, both of them will be positive. And you see if there is any signs of right ventricular strain on echocardiogram or on the CT scan. If your patient end up in these three high-risk patients, high or intermediate, and mainly what I'm talking about, intermediate high-risk patient. Those are the submassive PE. Those are the patients that we don't have a lot of studies and we don't know exactly what's the next step in these patients. Yes, we have guidelines, but it's not based on a big evidence. That's why this is the area where we'll talk about today. All right, that's the risk of like how many patients that will come. If you look at it in here, we have the intermediate low and the intermediate high. They are the majority of patients. That's why we really care about these patients. All right, so management of PE. I'm not talking today about like when should we use oral and IV, or when should we switch, should we bridge or not, and when should we start oxygen, and what's the like inhaled nitric oxide. If I'm gonna talk about that, I need like at least 3 or 4 ground rounds. But today we'll talk about the TBA and the use of TBA and catheter-directed therapy for PE and the treatment of PE. We'll start with massive PE. We all know, if like when I started in medical school, like, oh, if this patient has pulmonary embolism with hypotension, call for TBA. We're gonna give him TBA and that's it, done. When I went back to see what's the evidence behind it, this guideline, like over 30 years ago, it was based on only one randomized controlled trial that was done on 8 patients, divided 4 and 4. The 4 who used thrombolysis, they survived. The 4 who did not use thrombolysis, they died. So since then, we said, okay, then any patient who has massive PE, he has to receive TPA. And after that, they had a lot of like other trials, which is more of them are observational, small trial, or like retrospective trial, but there is no randomized controlled trial for the massive PE. I've heard there is one going on right now for the catheter-directed therapy, but not to compare to give TBA or not. But we know that if you don't give this patient TBA, they will die. So that's like, we all know that answer. So they did the meta-analysis after that to multiple trials, and they found in this meta-analysis comparing like the patient who received TPA comparing to the patient who received only heparin. But unfortunately, these meta-analysis, they did not have only massive PE. They have submassive PE with it. It was not like a straightforward trial. So we cannot judge on these meta-analysis as the randomized control trial. So all of these meta-analysis have like total of 2,000 patients. And they found the mortality improved by using thrombolysis. Mortality in the thrombolysis group was 2.3%, and the mortality in the control group was 3.9%. So there is improvement in mortality. But as we mentioned, this is just a meta-analysis for multiple trials. This trial was done in a combination of massive, submassive, and low risk PE. And in here, they found that the patient, they have the risk of bleeding was 9.9%. So we know when we have massive PE, we have a high risk of bleeding, but the survival is higher than the risk. So yes, you might have intracranial bleeding or non-intracranial bleeding, but if I don't give you TPA, you will die. That's how was the treatment before. But nowadays, we have the options that more than like TBA, we have the catheter-directed therapy. And some smart people, they came and they said, okay, so in the past, they used the dose of 100 milligram of TBA. Can we use lower dose? Is that the same effect? At least with less side effect, with less bleeding. So they tried 50 milligram instead of 100 milligram. And they found there is like, and as I said before, it was not only high risk, it was mainly intermediate risk, but 1/3 has high risk PE, which is the massive PE. So that's why the guideline did not change according to these trials, because all of these trials are not like a strong trials or straightforward trials. But what they found the effect was exactly the same. If you give 100 milligram or 50 milligram, the effect the same. How did they calculate the effect? They gave the 100 milligram and they gave the 50 milligram, and then after 24 hours, they remeasured the right ventricular pressure and the right ventricular size and the right ventricular strain, and they found it's improved and exactly the same in both group who received the 100 milligram and the 50 milligram. And then after in 2018, they did it again. They tried the 50 milligram and 100 milligram, and they found that it's exactly the same effect on mortality, and it's exactly the same effect on improving the function of the right ventricle, but it's exactly the same effect, the same rate of bleeding. So then they said, okay, so we don't have the 100 milligram, we have a randomized trial for it. The 50 milligram, we don't have a randomized trial for it, and we have the same effect, the same bleeding risk, the same everything. So guidelines said just stick with the 100 milligram for patient with massive PE. We are talking about massive PE or patient who has hypotension. Then intervention radiology, and we are super lucky that we have a very active group of intervention radiology and intervention cardiology in our program in here, that they do a lot of catheter-directed therapy. So there's a group that they came out and they said, okay, why we don't use catheter-directed therapy? What does that mean? Like they will go with a catheter straight to the pulmonary artery and they will give TBA in there, or mechanical thrombectomy. Now, every year you will have a different way of doing it, and every company will have a newer machine with more fancy way of taking out the clot. But unfortunately, there is no study, there is no randomized controlled study was done comparing the catheter-directed therapy to thrombolysis in massive PE. So most of them was a small trials, and they were retrospective trial or one-arm trial, and all of the main one was in 1988, and in that time when it was done, they found that the rate of bleeding is exactly the same. So they said, wait, if the rate is bleeding exactly the same, and we are not familiar with that catheter-directed therapy, because in that time, it's very small people that they know how to do it. They said, you know what? Then let's just stick with the TBA, and there is no need to change it. So that's why till today, and actually this year, 2021, CHEST guideline and ATS guideline and European guideline, it still says massive PE, use TBA from the peripheral line, and that's the main treatment. What's about submassive PE? Submassive PE, which we said it's the intermediate risk, when patient has normal blood pressure but has signs of right ventricular strain, high troponin, high BMB. What can we do? So we know now the treatment, if I ask anyone, they will say, yes, we give him anticoagulation, no thrombolytics, and that's the treatment, done. And that's the guideline. But in these patients, we said they can decompensate all of a sudden while they are in the hospital. They can get to massive if we don't act rapidly. So what they did, they said, okay, let's give this patient TBA exactly the same as massive PE. So there is 3 main trials was done that they gave TBA to these patients. So patient with submassive PE, means the patient, they don't have hypotension, and they received TBA. So these trial, we have the MABIT-3 trial in 2020, and MABIT-3 trial, it was in Germany. There's 49 centers in this trial was involved, and it was randomized. They randomize the patient. If you have submassive PE, I will give you TPA with heparin, and the other group will get heparin with placebo, and that's it. So they found, when they did this trial, they found that when you give TPA to submassive PE, you have faster and like a rate of like decreasing the pressure and improving the function of the right ventricle. And there is no like significant effect in mortality, and the bleeding was low. The bleeding risk was lower than the bleeding risk was the same as the heparin and or heparin with TPA. So there is no, like they said, okay, so if I give TPA to submassive PE and that will improve everything, then let's just give TPA to massive PE. But then when they went back to this trial, they found this trial was a weak trial because they have a lot of like mistakes has been done in this trial. And they said, no, we cannot change guideline according to one trial. We need more to give to change guidelines. So then in 2013, they came with the MOPET trial. MOPET trial, which is another trial that involved 121 patients. And in this trial, they used lower dose of thrombolytics. Instead of giving 100, they give only 50. And they said, let's see if that will help in submassive PE. And in this trial, they found the same. Yes, if you give TPA, that will decrease the pulmonary hypertension incidence, and it will decrease the incidence of recurrent PE, but there is no effect in mortality. Oh, that's good. So we have, at least we have something that will improve by giving TPA, but still has a bleeding risk. So then in 2014, which is the biggest trial in submassive PE, which is the beta trial, and that showed that in this trial, they involved like 1,000 patients. And it was randomized multi-center trials in the United States and in Europe, and it was double-blinded trial. And in this 1,000 patient, they give half of the patient, they give them like TPA with heparin, and the other half they give them heparin with placebo. And they found yes, if you give TPA, that will decrease the risk of decompensation, that will decrease the risk that the submassive PE will change to massive PE, that will improve the right ventricular function, but unfortunately, the bleeding risk is high. So that's why they said, oh, then if the bleeding risk is high and there is no benefit in mortality, and after like few weeks, the patient with heparin, they have the same effect in decompensation, then they said, that's it, we need to stop, no TPA for submassive PE. Some other scientists, they came back to the same trial and they tried to look what's the range, like how many of these patients that they decompensated. So they went to the patient like as a general, and they found the patient with submassive PE, only 5% they decompensate to become like massive PE. So that's why they said, let's stick with the same treatment. If you have submassive PE, just give heparin because there is a risk of bleeding. And that's the numbers, that the mortality was 2.17 in the thrombolytic group and 3.89, which is, there is a statistically significant mortality difference. But if you go like to the bleeding in here, the patient has, the major bleeding was 7.74%. So it's almost the same like the major bleeding that happened with the massive PE. So that's why they said no TPA with the peripheral catheter to patient with submassive PE. Then nowadays, we started to have the catheter-directed therapy, that's the main talk for today, and not the main talk, but one of the main talk for today. And the main discussion for any patient with PE should be around, should we do catheter-directed therapy or not? It should not be an easy answer. It should not be, oh yeah, he has a PE, submassive, take him to catheter-directed therapy. No, it should be like you sit down, you think, you have like the intervention cardiologist, you have the intervention radiologist, you have the ER physician, you have the internal medicine physician, you have the pulmonologist and critical care, and you sit and think together what's the next step in these patients. So when they did the catheter-directed therapy, they found catheter-directed therapy, it's like very helpful in these patients, and it reduced the right ventricular pressure very quickly, and it has less side effect compared to giving TPA from peripheral catheter. But in that time at the beginning, they didn't have trials to prove that they are right. And then starting from 2013, they start having trials. The first one was the Ultimate trial, and the Ultimate trial, they used catheter-directed therapy. They went with the ultrasound catheter-directed therapy to the pulmonary artery, And in that time, the Ultima trial, they have around 60 patients, and they gave a small dose of TPA, which is 10 to 20 milligram TPA inside the pulmonary catheter. And they said, like, they were looking at the improvement of the right ventricular function, and they found that there is within 24 hours you will decrease the pressure in the right ventricle, and you will improve the right ventricular function without any increased risk of bleeding. Then in 2015, there is another two trials, the Seattle trial and the Perfect trial, and they found the same thing. They found that if you use catheter-directed therapy, within 24 hours to 48 hours, you will reduce the pressure in the right ventricle, you will reduce the rate of decompensation to massive PE, and there is not a lot of side effect or like hemorrhage from the catheter-directed therapy. But those trial was a single arm trial. They did not compare it to giving heparin only. But then Optilus's trial, which is in 2018, a few years ago, that was one of the biggest trial in catheter-directed therapy in submassive PE. That was 17 centers in the United States was enrolled in that trial. And what they did is they divide them to multiple groups. And in this trial, they said, what's the lowest dose of TBA I can give that will break the clot, and it will give me like almost to zero risk for bleeding. So, and they found if you give like TBA 22 milligram per hour for 2 hours by the catheter, that's sufficient enough to decrease the clot and improve the right ventricular function and improve your decrease the decompensation rate. Since then, or since 2015, people, they start using catheter-directed therapy more than before to treat patients with submassive PE. But you cannot just do it for everyone. You have to sit and think what's the one that you do it, which patient you should do catheter-directed therapy for. And then the next one, which the mechanical thrombectomy. You don't use TBA at all. You just go in and you remove the clot mechanically. That was the FLAIR trial, and they found that there is very low risk of bleeding from the procedure site itself, but there is no intracranial hemorrhage, or there is no non-intracranial hemorrhage, and it was like very significant to reduce the burden of the clot itself. All right. So in here, if you see, like in the patient who received the catheter-directed therapy in submassive PE, it was the non-intracranial hemorrhage was 4.3%, and the intracranial hemorrhage was 0.7%, which is very low when they used, comparing to 9.9 when you use a TBA. Here was only 4 when you use catheter-directed therapy. The last one, which is my patient, the first patient that I had. Okay, let's say that you have a massive PE, and then you give him thrombolytics through the catheter, like the peripheral catheter, like a peripheral line, but unfortunately it did not help. The patient still have a PE, the patient still decompensating. What's the next step? So in here, actually, there is no answer. So like it depends on where you are, and it depends on who you are, and it depends on the patient himself. So if the patient has high risk of bleeding and you already give him one TPA, you cannot give him another TPA because he will bleed for sure. But if the patient, he doesn't have high risk of bleeding, and you give him one TPA and you are in a facility that you don't have catheter-directed therapy, you can repeat a lower dose TPA to treat this patient. And that's what I have done to my patient, the first patient, and I gave him another 50 of TPA, and that was sufficient to make him survive this PE and stay in the hospital, and like he didn't die from PE. So, but if you are in a facility that has catheter-directed therapy, the best answer is go with the catheter-directed therapy. If you fail the TBA, go with the catheter-directed therapy. There is a study that was done in Turkey, and that showed that if you repeat TBA, that will increase your risk, which that's obvious. And if you do like catheter-directed therapy, that will have the same risk of bleeding, but with more benefit if you repeat it on patient with submassive PE. Sorry, I had like a long to explain to you about the submassive and massive, but it's very important to know about the submassive PE, the high risk the PE, and the intermediate risk PE. And that's from where the BIRT team started. The BIRT team, which is the pulmonary embolism rapid response team, and those are like us, pulmonary critical care, vascular surgery, intervention cardiology, intervention radiology, hematologist, pharmacist, and ER. And if you look at all the requirement, like we like gladly that we have all of these subspecialties. We have an active IR team. We have an active cardiology team. We have like pulmonary critical care team. We have like expert ER physicians. So pharmacists. So the only thing that we need to do is to grab them all together and sit in a one room and build up a BIRT team. And because we have like a very supportive chair in our division and in our entire medicine, so I'm starting the first step in working on this and building up a BIRT team. And I think that will be very helpful to our facility, and it will be very helpful like for other facility around us. They can transfer their patient to us, and that will help to categorize the patient and know exactly which patient should go to the ICU, should go to the catheter-directed therapy, should go to embolectomy. So, and that should start from the ED. So from the ER, when you have a patient with PE, we'll have like an algorithm that you follow as an ER physician. You should call the BIRT team when the patient has massive PE or submassive PE. So if you are in the emergency department and you have a patient who has, or in the floor, you have a patient who has a PE and his blood pressure went down, that's a massive PE. If it's a massive PE, that's a consult for the BIRT team. You call the BIRT team. But wait, you just told us that if it's massive PE, just give TBA. That's right. That's for the straightforward answer. But those massive PE, you might have that patient who has contraindication for TBA. You have that patient, he has like a relative contraindication, not absolute contraindication. So that's why you need to consult, to sit together, and it's usually virtual meeting, and it doesn't take more than 5 minutes. That if the next step will be systemic fibrinolytic or catheter-directed thrombolysis or catheter-directed thrombectomy. It doesn't mean if you have a high risk of bleeding, we cannot fix your PE and we should let you die from PE. So we have multiple options can be done by IR and intervention cardiologists to help with this decision. And then we have the main area, which is like more around 95% of PE patients, the patient who has intermediate risk. If it's low risk, you don't have to consult PE BIRT team. It's low risk, start anticoagulation. If something happened in between, you can consult the BIRT team. But if it's intermediate risk, patient has right ventricular strain, has positive cardiac markers, then what's the BIRT team that they can sit? Like if I have an 80-year-old who's bedridden and he has submassive PE, so can you give the risk and give like the catheter-directed therapy to this patient, or should you just go with the heparin? And what's the the only difference, I will improve his or her right ventricular function to a patient who's like just sleeping on the bed, doesn't like, and he doesn't have a quality of life, and I might give him the risk of the procedure itself. Comparing to someone who's 35-year-old, like the patient that my second patient in the case presentation, 35-year-old who's an active person who's working on daily basis. If you just give him heparin, he might stay in the hospital for 5 to 6 days, and then he might decompensate or he might go home, but he will not go back to his baseline from the first week or two because his right ventricle is not working in the normal way. But if I do catheter-directed therapy today, he will go home after 2 days and he will go back to the normal function and a normal right ventricular function. So that's why BIRT team is very important in our hospital, because we have all the facility to start the BIRT team. And this is some of the data from other BIRT teams in different hospitals, for Mass General Hospital, Cornell, and Cleveland. And that shows that they use like how often they use like catheter-directed therapy and how often they use mechanical thrombectomy. And if you notice in here, our IR team is very aggressive in using catheter-directed therapy, which is very awesome if we can use this skills with like more organized fashion and more organized way for all of us as an internal medicine department. That's the second patient. Clot was removed, and the 36-year-old patient, and he survived, and he went home after 3 days without any complications. Thank you for being here, and sorry if I was talking a lot, and if you have any questions, if I can answer, I'll be happy to. If I can't, maybe the people smarter than me, like Dr. Khawaja or Zaid or Shwihat, can answer these questions. I'm open to questions.
Hey, good morning. This is Katie Adams. I do have
Yes.
a question. This was a case I had recently. I had a patient who he was actually doing okay. His cardiac markers were normal, but he had a saddle PE actually. And when I scanned his legs, he had a very large clot in just one of the legs extending into the popliteal vessels. In a situation like that, is it safe to just do an IVC filter, or should you consider doing thrombectomy or catheter-directed therapy? Because he was fine. He was actually on room air and normal sinus rhythm and everything.
I gotcha. That's a very good question. So you can take care of this patient in two ways. So the first way, you can, like, after you evaluate your patient and you see his risk for bleeding, risk for worsening, and as you said, having a big DVT and the saddle P, that's a very high risk that this patient can decompensate to like become submassive or massive P. And you check his troponin and proBNP in the first day, that was normal, but we didn't know if after 2 or 3 days it will get worse and it will have strain. And the other thing that we didn't know if when he gonna decompensate, and we didn't know if he gonna decompensate or not. He might not decompensate at all. So you will like put the patient in the discussion. You will explain to the patient and say, hey, you have a big PE, saddle PE, and you have a DVT. So that can move to your lung and give you more clot, and it might like give you a sudden death in 5%. And in 5 to 10%, like if 100 people, they come to the hospital like you, 5 to 10 of them, they will decompensate and they will die from PE. So what we can do is we can go in and do thrombectomy with a catheter-directed thrombectomy and place a filter in the IVC to prevent that clot to go up while we are treating it, and it will be like just a temporary thing. After a few months, we'll bring you back and remove that filter. Or if we can just we will give you just heparin and watch you in the ICU closely, and I will do an echocardiogram today, an echocardiogram in 72 hours to see the function of your right ventricle. And I had a case like that, and in 48 hours, his right ventricle function start to get worse. So we did a catheter-directed therapy for him to make sure that he will not get worse and worse more than that. I hope that answered your question, Katie.
It did. Thank you very much. I appreciate it.
Megri, this is Mustafa. Can you hear me?
Yes, I can hear you, Dr. Mustafa.
I think I have some observation and remarks, but probably you read the literature, the recent literature, more than me. But the issue here of the submassive PE, that we have time to address. I mean, it's like we have time. It's not like the massive.
You're right.
We have maybe how much? 10, 14 days to give the thrombolytic. So I have a window. The window is bigger than the thrombolytic for stroke. So I can delay things a few hours until the morning, for example, until you have the full team or the expertise to deal with.
Right.
So the massive PE, the massive PE is a massive, you gotta act now. But the submassive, I have time. So, for example, your patient, the first example, who had a massive PE, and you give him thrombolytic, and then you review the image, and he still has significant burden of clot, but hemodynamically more stable, for example. I think he switched from a massive to a category of submassive. And so my feeling here is like people should not rush into management of submassive PE, for example, in the night. I would rather keep things until the morning if possible.
Right.
And do this. The other thing I want to add is like the function of the per team should include all this query or controversial decisions, like, for example, subsegmental PEs. So you find subsegmental PEs and patients with high risk of bleeding, for example. And we have cases that being presented in M&M here,
You're
where
right.
they were anticoagulated and they end up with complication, or other way around. So I think this is also another point to add for, is like, so they always the controversial in the PEs, the two S's, the submassive and the subsegmental. And this is my remark.
Yeah, as actually Dr. Kawaja, he just like 2 days ago we were talking, he said like, hey, try to put like subsegmental PE in your presentation. And I had like a full slide ready for it, but I said the time will not like save us to talk about subsegmental PE, but I agree with you 100%. Subsegmental PE and for the guideline till like the most recent guideline in 2021 in the most recent CHEST meeting, they don't have any evidence behind it, and they still like debating between you start treatment or you follow the patient, or you like is it incidental, it might progress or not. So unfortunately, we did have an answer, and I agree with you, Dr. Mustafa, that this has to have like a team decision, not a one-person decision. And as I said, I'm happy if you have any PE patient, you have my phone number, you can call me, anyone, and before we start the per team, I'll be happy to help in taking decisions. Any other questions?
Okay, this is Al-Hamdani. Thank you, Dr. Megri, for your presentation. I mean, it's really a large topic that you tried to summarize in a short period of time. I just have probably a couple of comments. Number one, using a filter in most of the cases, it's not needed. Really, the indication of filter is so limited, and unfortunately, in our centers here, we're probably overusing IVC filter more than needed. I mean, there is very rare usage per guidelines for the IVC.
Yes.
And really, we don't have, as we are talking about creating a per team, I think, the person who put an IVC filter really should have a clinic for IVC filter, because that patient should be really followed in a short period of time, and that filter should be really taken out before it's too late. And unfortunately, we don't have this practice here as common. I hope one day it will be as a common practice where there is a special clinic for IVC filter. And again, like Katie Adams' case, I would not put a filter for that. I'll probably put a ECOS machine, a catheter, and just wait for 24, 48 hours. And if it's resolved, it's resolved. You have to understand that we're dependent on anticoagulation to really stop the propagation of clot. You shouldn't be worried about the clot in the legs if the patient is anticoagulated, but you will worry about the clot, the subtle clot in the pulmonary artery, because that can dislodge. So by putting a catheter and doing a directed catheter therapy, that should take care of the clot in the pulmonary circulation and pulmonary artery. And I don't think that the clot in the leg will be rarely dislodged if the patient is fully anticoagulated. There's a new tool called Inari. This will really, I think, will make a revolution. There is a randomized controlled trial just started in October of 2021 with the Inari catheter, and they are randomizing, about I think 600 patients in each arm. It's going to take a while for us, but it's it's probably the best tool that we have right now. And really, I mean, when you see the amount of clot at once, like once you successfully wired the pulmonary artery and took the clot out, it takes about 2 minutes. I mean, almost complete resolution of the clot from the pulmonary artery, the main pulmonary artery. And now, after that, you may need or you may not need a echo, therapy by ultrasound. Most of the time, nobody uses that after dislodging the clot. But that's really great talk. Thank you.
So, Dr. Hamdani, that's very important point that you mentioned. Imagine that, like when we have a PE, like this patient Katie mentioned, you sitting and one of us like sitting and one of the IR sitting, and we have this conversation before we take the next step. That's what I like about the PER team. Like you give you give your like expert opinion in here, and like the IR will give his expert opinion, and the critical care will give his expert opinion, and hematologist, so that at least you can take a right decision for this patient, as you said right now. And as you said, like the birth team, they have, like when you have a birth team in the hospital, you have to have a follow-up clinic. To build a birth team, we have to have a clinic that will follow up these patients after the patient has been discharged. And thank you so much for this comment. Any other questions? Any questions or comments on PE, guys? All right, I think we are good. Thank you again for being here. And as I told you, if you need any help with any PE patient, I'm happy to help. And we'll update you if we start the birth team in our facility.